My name's Adam Perler. I'm one of the co-founders, along with Andrew Bellis, for Florida Foot and Ankle Fellowship Society. I want to introduce Karen Lambert. She's head of FPMA. So Karen, if you want to pop up and say hi.
Thank you. Welcome, everyone, and sincerest thanks to each of you for being with us here this evening. My name is Karen Lambert. I am the CEO of the Florida Podiatric Medical Association. On behalf of the Florida Podiatric Medical Association and the Florida Podiatric Medical Society, it is with tremendous pleasure that I welcome you to the second season of the Roundtable of Excellence webinar series of the Foot and Ankle Fellowship Society's FFAFS, as better known. We were very lucky to have an excellent inaugural year, and we're looking forward to this next series, which is kicking off tonight with both Drs. Lamm and Dr. Nguyen. Thank you, Dr. Perler.
You're welcome. Thanks, Karen. So we are just very honored. We got started with this idea about 4 years ago. It was myself, Karen, and Dr. Andrew Bellis. And then we brought in some of the fellowship directors, and we started, talking through this idea of bringing all the fellowship society or creating a fellowship society by bringing all the fellowships together in the state of Florida. And last year was kind of our first real year at doing this, and we put together this webinar series to feature each of the fellowship sites, and it went really well. We learned a lot along the way, and we're really excited to bring this webinar series to everybody. Without further ado, I wanted to introduce Dr. Garrett Nguyen and Dr. Brad Lamm, who will be speaking on foot and ankle deformity, bone lengthening, and brachymetatarsia. So I'll hand it over to you guys.
All right. Yeah, thanks to Doug Loran and Orlando Production for helping us put this webinar series on tonight. The roundtable discussion is an excellent way to share concepts, ideas, and discuss things amongst not only fellow attendings, but all of us in the state of Florida kind of come together once a month for this series, and it's an excellent educational venue, and I'm proud to be part of the Florida Foot and Ankle Fellowship Society, and proud to present tonight to all of you. I'm director of the Foot and Ankle Deformity Correction Fellowship here in West Palm Beach, Florida, at the Paley Orthopedic and Spine Institute. Myself, who I'm the director of foot and ankle surgery here at the St. Mary's Medical Center. I'm joined tonight with my fellow, Dr. Garrett Nguyen, one of my 15th fellow, and he and I are going to discuss some of these principles about bone lengthening and lengthening for brachymetatarsia, some of the tips and tricks of the surgery, but also the principles which we want to share with you that'll hold true for treatment of these bone defects or bone deformities, whether they're congenital or traumatically induced. So, Dr. Nguyen, take us through it.
Perfect. It's a pleasure and honor to be presenting tonight. We'll be talking about bone lengthening and brachymetatarsia, principles and applications, as well as a new classification system. Our disclosures. So we begin with bone lengthening, also called distraction and osteogenesis, and we'll be talking about the fundamentals of distraction and osteogenesis, search techniques, as well as the temporal phases in the expression of growth factors and bone morphogenetic proteins. So regarding the fundamentals, Lizeroff originally described bone lengthening or distraction osteogenesis as the production of new bone between corticotomy surfaces during gradual distraction. These principles have been applied to foot and ankle surgeons to address deformities such as brachymetatarsia, malunions, non-unions, limb length discrepancies, traumatic and non-traumatic segmental bone defects, and revision surgery. Foundations for successful iatrogenic new bone formation requires 4 principles. These principles include correct osteotomy or corticotomy techniques, preservation of the periosteum and prevention of thermal necrosis, creation of vascular bone surfaces, and optimal distraction rate and rhythm. Regarding the search techniques, Elizabeth first described this as a percutaneous corticotomy over an osteotomy by preserving the blood supply of the marrow and periosteum. By definition, a corticotomy involves a transection of only bone cortices, leaving the endosteo marrow tissue intact. This is important and emphasizes the importance of the blood supply during osteogenesis. So what is the best location to divide the bone? Where should we make the osteotomy? Where should we make the corticotomy? Consideration of the pathological and histological characteristics of the metaphyseal and diaphyseal bone must be considered. Metaphyseal bone is more vascular, has a larger cross-sectional area, and provides better stability. However, possesses a thinner cortice, which is easier to separate. This location of bone leaves little room for fixation. Surgeons should only provide and use this metaphyseal osteotomy when addressing articular deformities when doing straight lengthenings. In consequence, diaphyseal bone also allows for more room fixation. However, it's a smaller cross-sectional area, but less bioactive. Indication for diaphyseal osteotomy should be limited to addressing only diaphyseal deformities. Regarding surgery techniques, there are 3 cutting methods that were described for distraction osteogenesis. First one is a classic Elizarov corticotomy. It's a percutaneous subperiosteal cortical osteotomy, often employed due to its preservation of the endosteo tissues and vascular nature. It's utilizing osteotome without a drill hole, resulting in more rapid and reliable bone formation. This technique, however, is more challenging due to the nature of the osteotome with less precise osteotomies or corticotomy. Second technique is the multiple drill hole osteotomy. Depending on the width of the cortex of the bone, surgeon can use a drill guide, K-wire, or drill hole, orthogonal holes to the bone at the level of the intended osteotomy. You proceed past an osteotomy horizontal across the tunnel to create a drill hole and rotate it 90 degrees in a vertical fashion to allow for corticotomy across the site of deformity. We'll present a case regarding this. We used SMO procedure utilizing the correct rules to utilize a focodome osteotomy with the drill hole technique. You can see in the picture going from left to right, the drill hole technique utilizing a focodome osteotomy. There's a video on the right utilizing the osteotome to create a 90-degree rotation to finalize a corticotomy in total. This can also be used as a ratchet technique in fashion in order to correct the deformity, and you can rotate it either clockwise or counterclockwise depending on the deformity correction that is needed or required. Pre and post. Current insights and techniques is the third and final, popularized and published by Lamm et al. It is a giggly saw osteotomy. If multiple osteotomies are needed in the bone or close proximity to each other, this technique allows for a clean transverse cut that does not require osteoclasis. Finally, temporal phases of distraction osteogenesis. There are 3 phases: the latency period, distraction, and consolidation. During the latency period, it begins immediately after the osteotomy or corticotomy and usually lasts between 5 and 7 days. This resembles the acute phase of fracture repair, formation of hematoma, inflammatory response, differentiating stem cells into chondrocytes and osteoblasts. IL-6 and IL-1 are also involved in the repair and upregulation to promote periosteal callus formation. Additionally, expression of the TNF and mesenchymal stem cells are used to organize the segmental defects in preparation for distraction. Abbreviated forms in the latency period can cause a lack of bone formation. Additionally, prolonged phase in this latency period can promote premature consolidation, so it's imperative that the latency period be optimal within the 5 to 7 days. During the distraction period, usually literature has stated rate and rhythm to be noted to be 1 millimeter a day divided into 4 increments. Although 1 millimeter is colloquially cited in practice, rate of distraction varies depending on multiple factors, including patient's age, health, medication, location of the osteotomy, as well as the procedure performed. In the foot and ankle, distraction rate can range from 0.5 millimeter to 1 millimeter a day. Distraction period consists of reabsorption of the periosteal callus and formation of fibrous interzone, comprised of 1, 2, 4, and type 10 collagen, ornated parallel to distraction surfaces. Distinguishing features is the presence of angiogenesis and neoangiogenesis regulated by the expression of VEGF. New blood vessels grow in loops between the collagen fibers to allow osteoblasts to reunite the area. This fibrous interzone thus acts as a scaffold for new bone formation, which forms by intramembranous ossification. This is distinct from fracture healing, whereas endochondral ossification is used by cartilage template. Finally, by consolidation phase, osteoids are progressively mineralized to increase and create bone formation. Additionally, TNF-alpha upregulates this formation as remodeling occurs. The longest phase of the distraction period is allowed for 1 month for each centimeter of lengthening. Consolidation is about twice as long for the distraction period in children, but may be 3 to 4 times longer in children or in adults. According to this, the amount of time is usually 1 month per centimeter in children, while we allow for 2 to 3 months per centimeter in adults. Finally, daily clinical use, we consider consolidation to be achieved when tricortical radiographic consolidation on 2 orthogonal radiographs. In the foot and ankle cases, a CT may be necessary to confirm complete consolidation, however, that's rarely used. Obtaining the endpoint allows for removal of external fixation. With that said, we'll go for application and clinical practice, and Dr. Lamm will go ahead and talk about brachymetatarsia.
Great. All right. Thanks, Dr. Nguyen. So, brachymetatarsia, as we know, patients present with shortened fourth metatarsal bone is most common. It can be multiple bones on one foot or bilateral. This is a case of kind of before, during distraction, and after distraction. And you can treat brachymetatarsia with multiple metatarsals at the same time. The beauty of external fixation is you can be weight bearing the whole time during all 3 phases, as Garrett mentioned, the latency, the distraction, and consolidation phases can be weight bearing. And typically, external fixation is used for the longer lengthenings. Sometimes the bone graft can be used for a single stage and shorter lengthenings. This is a topic I've published quite a bit of information about over my career, and a point of interest of mine. A couple different articles, this one in Journal of Foot and Ankle Surgery, which talks about the percutaneous technique, spanning of the joint, and even some book chapters and obstacles, complication, or problems, obstacles, and complications article. Patients usually exhibit, that dorsally displaced toe, as you see here. This is just an example of a traumatically induced horse stepped on this lady's foot on the right, which was traumatically induced, versus a congenital, where you see it's a kind of a ray deficiency, where you see a shortened metatarsal, but you also see shortened phalangeal bones. So these are examples of brachymetatarsia, and it is pretty common, 1 in 1,800 to 1 in 4,500 patients. The female to male ratio is pretty high, 25 to 1 female to male, and the premature growth plate closure of the metatarsal is what occurs. This is something that it's not seen as an infant or toddler, but at age 8, 9, 10, it becomes more evident as the metatarsal stops growing and the other metatarsals continue to grow. So here's just an example of the traumatic. On the right, you see the phalanx, the proximal phalanx is longer on the 4th than the 5th, but that's not the case on the left, which is the congenital. You can see it's a ray deficiency, that the proximal phalanx of the 4th toe isn't the normal length that you see in typical anatomy. So this is the appearance. It can be brachymetapodia if you have multiple metatarsals affected. Pain, they don't like the appearance, and it is a functional and cosmetic problem. It's important to look on the sagittal plane. You see how the toe is really dorsally dorsiflexed on the first metatarsal, or on the metatarsal head. So that has to be addressed during this procedure. You can see the position is quite high and almost somewhat of a joint subluxation that the patients start out with. So it's not only a metatarsal and length problem, but it's also a joint problem. So you have to be very mindful of the toe. And when we talk about lengthening, we want to do it in a safe fashion. So we don't want to ever sacrifice length for function. So the metatarsal phalangeal joint is very important. So a short first metatarsal is a bit different. You see that there's a declination issue. I know it's maybe difficult to see on your screen, but usually it's a plantar flex first metatarsal because it's the base of the first metatarsal that holds the growth plate that gets stunted or doesn't fully grow. And that's something where when you lengthen this metatarsal, you don't want to continue to lengthen in the vector that it sits in, or you'll create a cavus foot, and that's been published as well. This is something I've been working on for quite a while. It's a classification. It was just recently published, this concept and the treatment of these different classifications of brachymetatarsia just this past summer. It's A for axial, meaning it's a short metatarsal. So 4A is a short fourth metatarsal. A 4B is a bowed fourth metatarsal, because sometimes you see that bowing of the metatarsal in addition to the shortness. And then C is when you have joint issues or the congruency of the joint is malaligned. And so these classifications help to predict what's the best surgical plan. And so that's the problem with the traditional. Everybody's worried about, well, how much length do I have to grow the toe to make it longer? Well, it's not all about length. It also has to do with the morphology of the deformity. And so these classification system really helps you to identify what not only is the length issue, but what also is the deformity issue. So a 4A, as I showed, here's the 4B with the bowing. And sometimes you see the 4C occurring where you have a really dislocated joint. Sometimes I see these in my revision cases. Unfortunately, I see not only virgin cases, but a lot of revision cases these days where patients didn't get quite the outcome they were looking for. And you see these joints that are just devastated by the attempted lengthening. And then the 4D is just if you have a digital deformity. Sometimes we see phalanx problems with these patients, or shortened phalanxes as well. So you have options. You can do acute lengthening with bone graft. You can do gradual lengthening, which is my preferred method, and I'll tell you why. Or you can do some sort of combination. Those are the options out there. Gradual lengthening, here's just a case that came to me who had a patient who had gradual lengthening. And basically you can see the pre on the left, the post on the right. You have a bone graft, pinning, plating, whatever the concept that you want to use. But what you have with these bone grafts is it has to heal both distally and proximally. And the larger bone graft you put in, it asks a lot of that metatarsal to heal. So in this case, the bone graft healed proximal but didn't heal distally. And this was a difficult case to salvage because now you have a very frail, small metatarsal head to try to preserve the cartilage and the bone. So this is something where I think that the osteotomy and bone grafting should be more in the shaft of the metatarsal, and also it is a concern with these bone grafts. So again, I do prefer gradual lengthening in most cases. If it's under 10 millimeters, I will consider an acute lengthening, but anything 10 millimeters or more, I'll do gradual lengthening, and that's been very successful for me. You need to do some preoperative planning. Patients want to know, how much length do I need? How long is it going to take? And this is an example. If you have 15 millimeters of defect, then you want to do a 0.5 millimeter day as our rate for gradual lengthening. It'll take you 30 days. You have to add, as Dr. Nguyen talked to us about, a 5-day latency period, which is typical for these osteotomies of the metatarsal. Then you have 35 days, and then they'll be done with their lengthening period, and then they have to consolidate, which can take up to maybe 3 more months, which gives you an average about 4 months with treatment with this gradual lengthening. The application of these external fixation devices is very important. You must build not only a stable device, but a device which is going lengthen in the vector that you wish to lengthen in. So here is just a 2-pin fixator that we talk about, the position of the metatarsal pins. 2 points define a line. This is geometry, and once you have 2 pins, you can define the vector of lengthening. That's very important that this is evaluated when you're applying the fixator, so you don't end up lengthening too close to the lateral metatarsal or too much drifted towards the medial metatarsal, because you'll have toe deformities that follow. So in the old days, we would apply the fixators and pin the toe so it would hold the toe into the proper position. We tried to remove the pins kind of halfway through the treatment, all of which created a stiff toe joint. So we've gone on to this technique where you have a fixator that not only lengthens the metatarsal proximally, but also holds the joint in the corrected position, but also can distract the joint, so you do not get a joint stiffness problem or joint deformity problem, which is one of the most common problems with brachymetatarsia. So this is our typical construct. It's an external fixation device. The pins are 2.5 millimeters in diameter, so very strong, thick pins. The thicker diameter of the pin, you have exponentially stronger fixation stability. So these are very stout fixator and pins to allow patients to weight bear and allow for gradual lengthening without deformity. Here you see an example of this, holding the joint in a proper position while doing the lengthening. You see on the left, kind of during lengthening, and then after consolidation on the right. This is what it typically looks like. Usually, if you have a stable fixator, the pin sites are pretty clean, and the position of the toe is maintained throughout the distraction period, kind of a before and after picture. Patients are weight bearing during the entire treatment with the surgical shoe. This is something that allows for better bone loading and healing during the process, and patients appreciate being able to weight bear. This is a case of a 14-year-old patient with brachymetatarsia bilateral. Just to show you an example, again, you can calculate the distance you need to make the parabola line up. You put in your pins orthogonal as shown here. We put in pins in the phalanx, as you see here as well, to span the joint. A small incision laterally, a multiple drill hole with a 1.8 millimeter wire across the metatarsal, as you see here. So after you make the multiple drill holes, then you can use your osteotome, create the osteotomy, and rotate the osteotome, as you saw in Dr. Nguyen's presentation. This is a metatarsal. Make sure it's displaced so that you get a full, complete osteotomy. Once the osteotomy is complete, you close the incision and apply the external fixation device. Make sure it's in the correct alignment. This shows you at the end of lengthening. Now she has great function, good position of the toe, and as I mentioned, length is important, but function is very important, much more so, and this is the end result. So you can get complications. Like I said, the toe can rise up, it can go down. Because you're lengthening the bone, all the soft tissues get tight and can pull that toe into different positions. I do not do any tenotomies or any kind of tendon releases. I let the foot the soft tissues stretch out to the new position. And so here's a complication that you don't have adequate fixation in the distal segment. The osteotomy is allowed to, distal segments rotated, and this allows for toe joint issues. So this is a case that a patient came to me then with subsequent toe joint concerns. This is a case of over-lengthening the metatarsal past the parabola. When you over-lengthen, you're going to create instability of the joint. Even though the toe was pinned, the joint became very stiff and problematic. So this is something where also it looks like maybe the lengthening was done at a too fast a rate. So the rate and rhythm, stability of the fixator, the principles you go by are really important because this fourth toe doesn't look too difficult to take care of, but once you tried to apply, to do these surgeries. They're very difficult, very complex. Each patient's very, very much different, and you really need to heed the warning of all these principles. Here's a patient. She came to me from Canada. She had previous lengthening somewhere else, and now you see she's got Freiberg's of the fourth metatarsal because they basically created a crushing of the joint because they didn't protect the MP joint during distraction. She was a marathon runner and couldn't even walk without pain when she came to me. So she's a 30-some-year-old woman, basically disabled from this procedure where somebody really didn't stick to the principles. So that's why, Dr. Nguyen and I shared with you kind of, all the needed information you need to know about, bone lengthening. And then you also have to be a very astute foot and ankle surgeons on top of this. So this is it's a small problem, but it's a very complex problem and needs to be really paid close attention to. So in summary, you got to bridge the MP joint that protects it so you have good function in the end of lengthening. You must take care to make sure the lengthening is correct in the right vector. You don't want to over lengthen, and it is a dynamic process. Most surgeries we do as foot and ankle surgeons, it's set it, forget it. And you cast them and you have your protocols. In 6 weeks you're doing this, and in 14 weeks you're doing that. But this is a dynamic process. Every week something can change. We can get a phone call on a Saturday night, something's not going well, because it is happening gradually over time, and you have to be a surgeon willing to take on those responsibilities and pay close attention to them as they occur. So here's a couple before and afters. This is bilateral fourth metatarsal brachymet lengthened with this technique. Here's a radiographic image of that. You can see nice regenerate new bone formation, restoration of the parabola. Here's another clinical example of a fourth metatarsal bilateral. Here's a case of a brachymetapodia, multiple toes being lengthened all at the same time, along with bunion correction with the lapidus with external fixation. So this is weight bearing right after surgery. Here's that same patient post-operatively with the lapidus fusion with the multiple metatarsal lengthenings. And now you can see how the toes all come together. When you lengthen the metatarsals, it does push all the other toes out into good position. Here's just a kind of a standard case we did recently. And this is another multiple metatarsal lengthening case. And these are very difficult when you get into multiple metatarsals. It's difficult for one, but multiple becomes a challenge. And we thank you for your attention, and we're happy to take any questions. A side note, these are my boys who are ranked first in the U.S. sailors and won that regatta this summer in San Diego. And this is Dr. Nguyen's slide here of his hiking adventures out west.
All right, thank you, everyone.
Great. Any questions from the audience?
That was a great lecture. If anybody wants to speak up, or you can put a message in the bubble and I can read it. I did have a couple questions. One is when you're doing the external fixator, I know with ring fixation, I usually tell my patients at some point during the treatment, at least one of the pins is going to have problems. And we might have to go back to the OR and either take the pin out or put a new pin in. When you only have these 6 pins, how common is it to develop a pin problem, and what's your workup for that? How do you go about it? Do you arrest the treatment to take care of the pin, or do you swap out? So if you could walk us through kind of that issue.
Yeah, great question, Adam. I think there's 2 things I tell patients. One is I as a surgeon have to do a good job, and what I mean by that is if I build a stable fixator, less chance of pin site problems. So you have to have, as I mentioned, kind of the right diameter half pins, which gives you stability, the right fixator, which gives you stability, and you have to make sure all the nuts and bolts are tight, and you have to put the pins in without burning the bone to create, necrosis, and later on that pin becomes a problem. So it starts with the application, and you have to be good as a surgeon. The other thing I tell patients is they have to do a good job. So myself and Dr. Nguyen in the office, we have a sit-down, long conversation. They videotape it on their phone. We have pages of instructions to, kind of help them with, what to do. But then they know how to take care of the pin sites. And the biggest problem is really swelling. So when the swelling occurs, the skin slides up the pin, and then when swelling goes down, when they elevate or whatever, the skin goes down the pin. So that pistoning of the skin-pin interface creates, dragging of bacteria into the foot and swelling, fluid coming out from where the pin and skin interface is. And that really creates kind of the snowball effect of that pin irritation. And so we really train them to wrap the pins tightly with gauze. So basically it keeps the skin down, and basically the gauze is a bumper between the black fixation box and the skin. So if you wrap tightly around all the pins gauze, you're not going to get that skin being able to elevate up the pin, because the gauze is keeping it down as a bumper between the fixator and the skin. And so we really train them well about taking good care of their pin sites with this gauze. We don't use any potions or lotions. We kind of just let them shower antibacterial soap and water, and then rewrap the dressing. If we do get an irritated pin site, we use betadine. And the other really important part, and I'll let Dr. Nguyen speak to this, is kind of patient education and attentiveness to patients. And so I know Dr. Nguyen's got calls already and been on the phone, but he can describe to you how to discuss this with patients when they call in or they're having trouble and sending us pictures on the internet.
Yeah, I think it's true to Dr. Lamm. What he said is it's setting patient expectation education. I think is crucial, especially when dealing with any kind of external fixator device. It's application as a surgeon, utilizing your tools, placing the external fixator pins in the correct position, utilizing proper technique to ensure proper recovery. I think that's one part, but I think the other part is also the patient education, compliance, and understanding, setting expectations. This is how it's going to feel day 1, day 2, day 3. This is your postoperative block. You should go and listen to the postoperative pain management, go to your ibuprofen, your Tylenol, and set those guidelines up for that you can get success in your postoperative protocol. And then also understand and listen to them, listen to their concerns, and be available. I think a lot of the problem with the postoperative protocol with any external fixators is the unknown for the patient. It's a big procedure for them, although we may do this often. They've been waiting their whole life, or they've gone through 20, 30 years and they haven't had the opportunity to do this. And when they finally have the opportunity to do it, they're over cautious, or they're very well educated. So they come with a lot of questions, but duly so. I think it's a good opportunity for them to kind of learn about the process as well, and I think it's our duty to kind of educate them and set the guidelines and set the standards for them, and I think that in combination of good surgical technique provides for a good outcome overall for the patient. So I think that is pretty crucial.
Yeah, and I think when people have questions, they'll come to the office and we'll talk about it, or if they're out-of-state patients, which we treat a lot of those patients, we get emails with photos, and we really have a strong hold on don't do anything unless it's approved by Dr. Nguyen or Dr. Lamm, because they're reading all this on the internet, they're putting all kinds of stuff on the foot, or they're doing things that could create more trouble for them than good, and they see a little pink and they start freaking out. So you have to be there for them. Dr. Nguyen, kind of handles a lot of those calls, and we handle them together. We talk to the patient, but yeah, this is a foreign body on their foot. They're not used to it. It's brand new to them, and you really have to be attentive to them, or they'll not do well, because they're overthinking it, or they're kind of doing what they think is right, but it's not really kind of approved treatment plan.
Yeah, I think anything especially with medicine, I think you would have to always treat your patient as if you're their own family member. always try to be available for them. We do have a fellow phone. We have a Team Lamm email that is open 24/7 for our patients to have access to us, whether it be me, myself, Dr. Lamm, or our staff. There's always someone that's available to answer their questions. I know sometimes those that go to a hotline, they don't get a call back within 24 hours. So having a personal phone number or an email that's accessible to multiple physicians and team members and clinicians alike, I think that allows for better patient outcomes and satisfaction, especially when surgical techniques and complications are a little bit higher with these kind of procedures.
Thank you, guys. That was awesome. And it answered part of my next question. I know we talked about ratio of lengthening, and I just can't recall if you mentioned the cool down period. So once you get to the length that you want, is there a ratio that you use? So if you lengthen 6 millimeters or longer, is there a certain amount of time that then you keep it fixed in place? And then can you comment also what the transition is once you take the pins out? And are they weight bearing right away in a regular shoe, or are they in a post-op shoe or boot? And at what point can they start to get into the regular shoe, get into walking? And then, I think you said you treated a couple runners. What would be the earliest somebody could run after a technique like this?
Yeah, so as Dr. Nguyen mentioned in our talk, that time to removal is a difficult assessment. In tibias, it's 3 cortices because you can see that easy on radiographs. But on a foot film, of course, you're looking through a lot of metatarsals on the lateral, so you really don't have that ability to see kind of the dorsal or plantar cortices so well. So it is something where you really have to be confident, I think, radiographically before you remove the fixator. In my experience, it is about a 4-month process, looking at 300 or so of my metatarsal lengthenings I looked through. It was about 4 months, maybe 4 months and a week or something on average. So it's usually about a month or 5 weeks to do the lengthening if it's around a 15 millimeter lengthening. And that's kind of the average length that most patients need, about 15 millimeters, as we found that as well. And so it's usually around 4 months total time. So consolidation does take a little while for these metatarsals, even though we're going at a half millimeter a day. And I think, the old adage is, a month, a week, taking the fixator off a week too soon is not good. You'd rather wait an extra month kind of thing. So in general, yes, they want the fixator off very soon, but we really look at our x-rays critically to make sure on that AP oblique that we see both cortices that are very strong on both images. And then once I see that, I feel confident I can remove the fixator. We do vitamin supplementation, vitamin D and calcium during the treatment time to try to aid in the healing process. Of course, kids heal quicker. If you're younger than 30, you heal bone faster than over 30. That's kind of the principle we go by, so we kind of mind that as well. As far as removal, we usually do it in the office, without anesthesia. Patients really are very well tolerant to that. They seem a little apprehensive at first, which is understandable, but once they go through it, they're like, really, that wasn't so bad. I'm glad I did it in the office. And then we usually protect them in the surgical shoe for still another month, 3 to 4 weeks before we get them back to normal shoe gear. We want to make sure that the pin sites are consolidated enough where they can weight bear in a normal shoe. And then I allow them full activity about 6 weeks after removal, that they can run and get back to full strength activities. And it's a process that as Dr. Nguyen said, we have a long conversation before surgery and kind of educate them on the typical process and educate them that there could be some, we may have to take you back to surgery to adjust a pin. We may have to, adjust something in the office. We prepare them for, there could be a time where they need a fine-tuning adjustment that's kind of off-scheduled, and we kind of prepare them for that as a possibility. Not typically something we have to do, but it can occur, and we inform them on that.
Perfect, thank you. And there was a question in the bubble. Elvis Dan was looking for a ride to the Bahamas and was wondering when the next regatta was. He wanted to hop on board with your kids.
Yeah, Dr. Dan's one of my former fellows. How you doing, Dr. Dan? He's up in New York City, so best wishes to you. We're hoping all goes well with the new family too. So anyway.
Thank you, guys.
Yeah.
What's going on?
Okay, well, does anybody else have any questions?
Yeah, I had a question real quick. Some of the other doctors are doing single stage for Brachymet. I was wondering what your thoughts are on that, any pros and pitfalls, using a bone block and bridge plate.
Yeah, good question. I think that is attractive to surgeons because as you heard me talk and Dr. Nguyen talk over the last hour, we've talked about the ins and outs of bone lengthening and gradual lengthening, and it's it is complicated. So to me, I think the easy way out is put a bone graft in because you can fix it there on the table, and nothing wrong with that. It's just as I mentioned, you should never sacrifice length for function, and so I don't typically use the bone graft because of that simple fact that you're stretching all the soft tissues and you're crushing the joint. You think of jamming the first metatarsal head into the phalanx, which is getting pulled back by all the soft tissues of the toe. And so, you can create that Freiberg's infarction that I saw. You can create a stiff joint that never moves. So my worry is you create a hallux limitus, not of the first, but of the fourth or whatever brachymet you have, and how do you treat that? So again, there's nothing wrong with that concept. It's just, I think we need, future studies to show, okay, well, this method or that method is better for these particular classification of brachymetatarsia. The issue with the acute lengthening is it's very difficult to be able to stretch the metatarsal acutely over that 10 millimeters I mentioned. Just from a technical standpoint, the foot doesn't allow that so easily. So it is a big technical challenge to achieve more than that, number one. Number two is, that's a long piece of bone graft that has to heal, and I worry that you can get some subsidence or delayed union or some non-unions with that, as I showed in my presentation. So that's my feeling on that topic, but I do think that it's something that I've seen a lot of cases that I'm actually treating one from Washington State. They did an acute lengthening, and now she's got a fused fourth MPJ because the acute lengthening didn't work. And it was trying to push the envelope, and it created her a loss of a joint. So I think you have to be mindful of what you're doing. It's easily to get focused in on what am I doing to the bone and forgetting the whole functionality of the foot.
Hey, Brad, to follow up on that question, when you put your fixator on, I know you said you like to do a little bit of an arthrodiastasis of the MPJ. Do you do that right on the table before you start to lengthen your corticotomy, or is that gradually built in as a separate lengthening as you're also lengthening your corticotomy?
Yeah, so good question, Adam. So I'll do a little acute lengthening in the operating room to add a little bit of distraction. I feel that helps because a lot of these patients post-operatively have a stiffer MP joint. But I've found that, with the technique of spanning the MPJ, I have patients that have really almost normal range of motion, or same as pre-op, they have post-op when I'm kind of protecting the joint with the distraction. So I don't really add any extra distraction like you would if you had arthritis of the joint, ankle joint or great toe joint like we do in some of those distraction arthrodiastasis cases. But I do add just a little bit to give a little stretch to the joint. I don't like to add too much because I feel like it creates, again, that more lengthening, which is stretching the soft tissues, and I don't want to overstretch it. But I don't add gradual throughout the process, although the device, you can add that if you wish. But that's kind of my typical technique. And from like I said, a functional standpoint, using this kind of bridge technique of the joint has worked really well to see the post-operative result of maintaining that joint function.
And I noticed that a lot of the presentations or cases that you showed, the toe was sitting in a cocked up dorsiflex position. So when you're putting those pins in the proximal phalanx, are you pulling that toe into a stretched out corrected position and then pinning it once it's in that position, like you're holding it and pinning it? Or are you, because obviously there's a little bit of a sagittal plane correction, but that fixator is very linear. So how are you doing that portion? Because your post-ops looked amazing. I mean, all the toes were equally touching the ground. So obviously there's some magic there that you're doing.
Yeah, good question, Adam. So the fixator, the last clamp, which is for the phalanx, that clamp is, sagittally swivel. It's a swivel clamp. So you can get some positional changes where, it doesn't have to be orthogonal pins to your orthogonal fixator. That swivel clamp allows you for some flexibility. And you're exactly right. The goal of using X-Fix for the toe is to do exactly that. You want to put the toe back down into a normal position, sitting next to, equal to the adjacent toes, and then fix it there so that not only can you distract the joint, but now you have a toe that's in line with the other toes and in the right position. So it has kind of a dual purpose where you're realigning the toe from being dorsal to being where it should be in a sagittal plane, but also allowing a millimeter or two of distraction of the joint, and then we go ahead and do the metatarsal lengthening.
I think it's pretty amazing because, all of us, I think we can all do really, really big procedures, but hammer toes are the most frustrating because it's almost like cosmetic surgery, and you can do a great hammer toe on an x-ray, but then you just watch over time the scar tissue draw it up, and it's because you're doing capsular releases and tendon releases. I think it's really interesting that you're getting these perfect positions and you're not even opening up the toe. And it kind of says something about maybe what we're doing right or doing wrong with our hammer toe surgeries.
Yeah, no, great point, Adam. I definitely try not to open the joint, just for that reason. It's what I find is just what you said, Adam. If you're doing a hammer toe, you open the joint, you're trying to do things, and it just, sometimes it doesn't work out. It's twice as bad if you do that for a toe that is a brachymetatarsia joint. It becomes twice as difficult of a problem that you would find with a normal hammer toe. So definitely a less invasive treatment has been very successful for me than the open treatment.
And Larissa wrote in, she said, is tendon lengthening a procedure you often use during revision cases?
What lengthening during revision?
It looks like just tendon lengthening.
Great question. Yeah, so the revision cases are very individualized. Some of them I have to open up because they had a previous plate and screw, or sometimes I have to open them up because they have so much scarring that the joint needs to be released. And again, just what you and I were talking about, Adam, I try not to open these if I don't have to, but and I can sometimes just distract the joint and toe into position rather than opening the joint. But yes, sometimes tendon lengthenings are needed for some of these revision cases. But again, the hopes is with this information, we wouldn't hopefully get into the revision procedures because those are extremely difficult. If you think of a hammer toe revision surgery, it's 10 times as difficult.
Just to follow on Larissa's question, if you get a case, it looks like you've gotten some cases where they had a previous acute lengthening, it failed, if you can determine that that graft is non-viable, what do you do on that? Are you removing it and then acutely shortening it and then lengthening with diastasis, or how would you handle that where you have maybe, let's say, a centimeter graft that just completely failed and now they have that big void there? Are you going to use your technique on top of that to kind of stimulate new bone growth and osteoneogenesis through distraction, or how would you handle that?
Yeah, they become very difficult cases because you have a devitalized skin envelope and you have a dead bone or partially dead bone, and you got a toe that's stiff and you got a big scar on top of the foot. I mean, it's difficult cases. So I look at it, did they achieve the length or not? That's number one, if they achieve the length, then, I may just need to put in, good autograft bone that achieves the goal of healing and maybe stable fixation, whether it's internal or external. But if they didn't achieve the length, a lot of times I go back, I'll do acute shortening and then lengthen because I know that I need the tissues to kind of, regenerate and then, build anew. Because what osteogenesis of the bone does is also create angiogenesis of the region to create, more healing of the tissues around there. So sometimes in these revision cases, doing some additional like coracotomy with lengthening is very helpful to kind of regenerate some of the healing potential in the region. So very individualized. I use autograft in these revision cases. I don't use any kind of allograft or that. You really need rigid fixation for quite a while. And I think the other principle is, as I've been mentioning all along, is the function of the MP joint. So, that's really critical. I would sacrifice a little bit of, kind of getting the bone to heal to fix the joint first and then get the bone to heal, because the joint is so paramount in these cases.
And one more rapid fire question and then we'll call it a night. Does vitamin D levels, is that taken into account when you're doing bone lengthening?
Yeah, so we put everybody on vitamin D at least 5,000 units a day. And we also use the ultrasound bone stimulators when we feel it's necessary, especially for like revision cases, but not on primary cases. We're not using the ultrasound, but everybody gets vitamin D for sure.
Excellent, thank you. Unless anybody has any questions, I just wanted to thank you guys again. This was really excellent. I wanted to thank everybody. Karen, thank you, and Doug. Excellent production tonight. We appreciate your help, and we look forward to more of these series and help us build the word and get more people to come out to these.
Thank you, everybody.
Thank you.
And have a great Thanksgiving, everybody.
Thank you, everybody. Appreciate it.